Hi, this is Dr. Adam Van Wert from Wilkes University's Nesbitt School of Pharmacy in Wilkes-Barre, Pennsylvania. I'm just continuing a lecture for our students on gout, and we're actually specifically at the point where we're going to discuss the renal handling of uric acid, and then basically the drugs, two main drugs that are on the market now that are affecting uric acid transport. I want to start off with just a brief reminder of the physiology. I don't really plan on going into a lot of detail on this because our students have already had this, but just to remind you, the some substances in the blood could be a drug substance or it could be an actual endogenous compound, can be bound to plasma protein. Just remember that the amount that's bound to plasma protein cannot be filtered because specifically albumin is too large to get filtered at the glomerulus. So uric acid also follows that rule. Okay, and here's some little detail on the numbers here in glomerular filtration, but I don't really want to get into that too much today. Okay, just a reminder of how that works. And then another reminder that once something is in the tubule, it can be reabsorbed through transporters. Once something, if it passes the glomerulus, it passes by it and doesn't get filtered, goes into the vasa recta or peritubular capillaries, there's an opportunity then for it to still get into the proximal tubule through secretion. And that's very specific transporters that we'll be discussing. I'm going to start off with a more basic image of how this works, and then we're going to get into a little bit more detail and some animations. If you just imagine this is one nephron. We chop off the glomerulus. We're looking inside the proximal tubule here. I wanted to highlight the major transporters that are relevant to uric acid transport. So one of them would be Urate1, and that is basically on the apical side or the luminal side where the urine is forming. That's going to allow uric acid to go from the ultrafiltrate here into the epithelial cell and then eventually into the interstitial space in the blood. Urt4, that is not as I would say that's not as new in the sense that Urate1 has been studied a lot more for urate transport, but Urt4 now is well known to do this as well. It also does pretty much the same thing. It is on the apical side, pumps urate or uric acid into the epithelial cell, and then eventually that can be transported back out or all the way out and then go into the bloodstream. These are both exchangers. I didn't want to focus on that too much, but it does mean that they require a counter anion. I don't want to spend too much time on that. Please ignore this artifact. That's from something that I missed when I was deleting some other things. Then one more thing that is relevant to reabsorption of uric acid, and again, that's kind of something we want. Well, it's definitely something we want to avoid. If we're trying to reduce the concentration of uric acid in the blood, we want to avoid reabsorption in the proximal tubule, and that's what the drugs will be doing. But something I think it's worth mentioning is this transporter GLUT9 that's on the basolateral side. That's been shown, at least in Italy, through a relatively diverse population of patients, a large population, that patients that have mutations of GLUT9 have a different blood concentration of uric acid, and specifically GLUT9 they found is important for reabsorption. So if that transporter is not functioning correctly because it's mutated, you will actually have less reabsorption of uric acid and more actually excreted in the urine. So that could be beneficial actually. So I imagine transporter inhibitors for GLUT9 will come out in the future. Again, that's in the future, but right now we also have Urt1 and Urt3. These are actually two different transporters that I put as one here for simplicity's sake. But Urt1 and Urt3 you could think of as opposing Urate1 and Urt4 because they transport uric acid from the interstitial space into the epithelial cell, and then it could eventually be transported into the lumen of the proximal tubule. So these are actually going in the other direction. Okay, so this is the physiology. Okay, and I have a little bit more detail in a brief animation to show you how this works. Okay, so all this can be happening simultaneously. So we can have urate going on Urt4 and then through GLUT9 and then back into the blood. urate going on the Urate1 transporter through glutathione back into the blood. We could have uric acid or urate going through O3 or O1 into the epithelial cell in the kidney, in the proximal tubule, and then back into the urine. So that this can go in either direction. Okay, so just you can start imagining then if I blocked O1 or O3 or Urate1 or O4 with a drug, that will impact the flux of uric acid across the membrane. Okay, and that will then have implications in vivo and in the patient. Okay, and I want to talk about what those implications are in a little bit. Okay, so if we add probenecid as our example here, again, that's an older drug, much older drug than the new one, Lesinurad. Probenecid actually blocks all four of these, O1, O3, O4, and Urate1. Now, it has a much higher affinity for O1 and O3. That means that at a lower dose or a subtherapeutic dose, most of the inhibition is going to be on O1 and O3. That actually is exactly the opposite of what we want to accomplish, because when you block these two transporters, urate cannot be eliminated through secretion. Okay, and it'll actually be accumulating more in the bloodstream, and it'll go right into the peritubular capillaries. Okay, so that's a bad thing. And that's why probenecid is kind of a double-edged sword. Depending on the dose, it has a different effect. If you give the therapeutic dose, you're still blocking O1 and O3, but you're also blocking O4 and Urate1. The ultimate outcome, or the net effect, is you actually do eliminate uric acid through the urine, and that's because some of it is filtered. And the net effect, like I said, is you eliminate it. You eliminate some of it, and I'm just showing you that you're blocking the transport, so we don't have reabsorption. Okay, so we have excretion of uric acid, and that's the goal. And that's why probenecid is, it's very important that adherence to that drug. Again, it's not one of the most common drugs used these days, but if it is used, if there's poor adherence to that, okay, and if someone's running with a relatively low concentration in their bloodstream, they could even worsen their hyperuricemia. Now, I have a brief mention here of Lesinurad again, but I'm going to get into a little bit more detail on that just in a little bit. These are two really important references that you can refer to and that I've used to generate these slides on Lesinurad. Okay, so I'm not going to read through this right now, this little statement, but just you could look at it if you'd like, but I'm going to talk about it just in a little bit. Okay, I want to pose a brief question before we move on, just to get you guys up to speed and remind you of what's important here when it comes to the renal handling of substances. The question is, are there important differences between the luminal and basal side of the renal epithelial cells? And the answer is yes. And I just wanted to remind you that the blood plasma, and that's throughout the entire bloodstream, but again, we'll be focusing here on the peritubular capillary blood. That plasma has drug-binding proteins, and actually more than 90%, I'd say 85 to 95% of probenecid is protein-bound, whereas Lesinurad is about 98, maybe 98.2% protein-bound based on the reports. That means that only a small percentage of these drugs goes from the peritubular capillaries into the interstitial space on the basolateral side of the proximal tubular cells. So, despite having a certain concentration, total concentration of the drug in the blood, you get much less at the actual transporter sites, binding sites on the basolateral side. Okay. So I'm going to go ahead and move on quickly. So this also means that the amount of drug available for glomerular filtration is low. So I just wanted to remind you again that it's going to hold true for both. So that means if there's high protein binding of a drug in the plasma, less will be available for transport, but also less will be available for filtration at the glomerulus. So that means you might conclude possibly that that may result in a similar concentration in the interstitial fluid on the basolateral side of the cells in the kidney, and a similar concentration then on in the lumen of the proximal tubule. And the reason why that's not correct is one really important difference on these two sides of the membrane. The luminal side will be reabsorbing water, And the more water you reabsorb, the more concentrated your solutes get inside the proximal tubule, and that means you'll actually get a higher concentration on the proximal tubule side. So we'll see in the upcoming animation a little bit of an example of how this occurs, how things can get more concentrated in the proximal tubule. Again, one mechanism is through water reabsorption. Okay. One more thing I wanted to address before we get into some more of the animations is just a little bit more detail on Lesinurad. Just in a reminder that Lesinurad has similar affinity for OAT1, OAT3, OAT4, and Urate 1, but reabsorption of water from the tubule will raise its tubular concentration, and that means, if all those transporters were on the same side of the membrane, then Lesinurad has a similar affinity for all of them, then it would have an equal chance to bind to any transporter there, to any of the 4 transporters. However, because OAT4 and Urate 1 are on the apical side, and in that water reabsorption occurs there, concentrating Lesinurad, that'll actually, again, because it has equal affinity for all 4 of the transporters, that'll give it an edge, and at that point it'll have a higher concentration on that side. So actually there'll be a stronger effect on OAT4 and Urate 1 than there will be on OAT1 and OAT3, because again, on the basolateral side, that drug is stuck on albumin. Okay, and not only is it stuck on albumin, but that's the main reason. It's stuck on albumin, but it's even got a higher protein binding than Probenecid does. Okay, now Probenecid has a much higher affinity, about 10 times higher affinity for OAT1 and OAT3. So even though Probenecid also gets concentrated in the proximal tubular lumen, because its affinity for OAT1 and OAT3 is so high, it still has not a dominant effect on OAT4 and Urate 1. In fact, it's probably going to be roughly, with a therapeutic dose, you'll still have a significant inhibition of all those, of OAT3, OAT1, OAT4, and Urate 1. So you're kind of relying on the filtration of uric acid in the presence of Probenecid to eliminate it. Okay, so one final point about that, and it's not an insignificant point, it's a quite relevant point. Probenecid, because it does have such a high affinity for OAT1 and OAT3, and I'm not saying it's not really a higher affinity than Lesinurad has, but Probenecid has a much lower affinity for OAT4 and Urate 1, and that means we have to give a higher dose. And when we give a higher dose of Probenecid than Lesinurad, that results in a lot of inhibition of OAT1 and OAT3, and that means drug interactions. Okay, that means any drug that's transported by OAT1 or OAT3 then can have impaired elimination when we give Probenecid. Now, in theory, that should be much less likely with Lesinurad, and at least for one article in one drug, they've studied that, and that would be furosemide or Lasix, brand name Lasix. Now it's been furosemide for a long time as generic, but that they showed, even though there was some effect on the pharmacokinetics of furosemide with Lesinurad treatment, the actual effects of it on urine flow or urine output and sodium in the urine were not significant. So that meant that it really had just a minimal impact on furosemide transport. Okay, so this is just to show, to make it clear, if we have at the top here, the white is albumin. Just imagine this blue rectangle is either Probenecid or Lesinurad. What will happen is, if it's on albumin, it can't get through the capillary pores. Okay, if it's free, it can get through, and then it'll block OAT1 or OAT3, and most likely both of them. Okay, with any dose, really, we'll have some blockade of OAT1 and OAT3 with Lesinurad and Probenecid. However, again, Lesinurad is more protein bound than Probenecid, so less of it will get into this interstitial space and block these transporters. Okay, and again, Lesinurad's concentration in the blood is much lower because we give a lower dose, and that's because we can give a lower dose because it has such high affinity for OAT4 and Urate1. Okay, so now if we look down here, okay, if something is getting filtered, one of these drugs are getting filtered, or both of them really, water will start getting reabsorbed very early in the proximal tubule, and then these drugs will get more concentrated in this ultrafiltrate that's going to become the urine, and that means the concentration here, the free concentration here, is much higher than the free concentration on the other side, even though basically protein binding affects leaving this capillary, and it also affects going through the glomerulus. This water reabsorption is what makes the difference to concentrate the drug on the apical side. And even if it had the same affinity for OAT1, OAT3, OAT4, and Urate1, like Lesinurad does, once you take water out of here, you're putting a lot more drug on this side, the concentration at least, on this apical side, so OAT4 and Urate1, which are the transporters that we actually want to inhibit for gout. Those will be inhibited more so relative to OAT1 and OAT3 when we give Lesinurad. I just want to show you some of the actual numbers. These are approximate numbers based on some of the references that I found, okay, and actually some the monographs for the drugs. Okay, so Probenecid, just to show you as an example, Probenecid, its peak concentration in the blood when given a typical dose, okay, and it does have a range of doses, but it's going to be about 521 micromolar. But because it's protein bound, the free concentration will be about 26.1 micromolar, whereas Lesinurad, its total concentration is about 29 with the therapeutic dose, whereas the free concentration is much, much lower, about 460 nanomolar or 0.46 micromolar. Now, if we look on the left here, this is really where the meat and potatoes of this, the evidence really would be. We have the IC50 here, and then the IC50 for the other drug down here. Okay, so if we look here, the IC50 of Probenecid for OAT1 and OAT3, it's going to be, from 5 to 10 here, and then 2 to 5. Somewhere in that range would be what the reports show. For OAT4, it's about 50 to 70. For Urate1, it's about 41.7. So that means there's a much higher affinity and inhibitory potential of Probenecid against OAT1 and OAT3. So, and those are not the transporters that we desire to inhibit for gout. So that creates a little bit of a problem, actually a significant problem, especially again for drug interactions. Whereas Lesinurad has a relatively similar affinity for all four transporters. And again, because of its concentration or concentrative ability of the proximal tubule, again, both of these drugs will be more concentrated in the lumen. But then this one, again, because we're already about an even playing field for these transporters, we're going to tip it to this side. So we're going to have a predominant OAT4 and Urate1 inhibition when given a therapeutic dose of Lesinurad. And if we gave a subtherapeutic dose, or if there was poor adherence, we miss a dose, or you have a low blood concentration, the nice thing is we don't have that low blood level predominance of the inhibition of OAT1 and OAT3, whereas with Probenecid, if you have a low blood concentration and subtherapeutic, you'll predominantly inhibit OAT1 and OAT3, and all that does is raise your uric acid concentration, which makes it worse. And yeah, you have drug interactions that you have theoretically should have much less of with Lesinurad. Okay, and that pretty much wraps it up. Okay, and I know it's probably a lot of detail, but because at least in the curriculum here, we don't get much detail on organic anion transporters for the rest of the curriculum. So I wanted to take this moment, this opportunity to spend a little bit more time on something that's becoming extremely important. As you may know, a lot of really all the new drugs that come out on the market are now required to undergo testing for the ability to be transported, or the ability to inhibit these organic anion transporters. Because of such a major drug interaction potential, that now you'll see all the drug monographs or package inserts will have information on these transporters and whether or not the drug interacts with them. And in just one last point, one of the things you might see in these monographs would be this ratio of the free concentration of the drug at that's the maximum concentration you'll see after a dose, the Cmax free divided by the IC50, and that's a good quick single number you can use to determine if there's a risk of that drug interacting or significantly inhibiting the transporter and then potentially causing interaction with another substrate for that transporter. So in this case, you see 3.4, 6.5. That means basically that means the Cmax is much higher than the IC50, which means we've gone well above the point at which there's going to be a significant interaction. That means there's a very significant interaction with the transporter, potential for affecting the pharmacokinetics of other drugs. Whereas here we're a little bit lower, we're lower than 1, which means the rest is going a little bit down. It's not insignificant because we're still close to 50% of the IC50, okay, but it's a little less significant than 0.1 and 0.3. Whereas if you look at Lesinurad, if you use the same method, Cmax free over IC50, you'll notice that if you look at 0.1 and 0.3, we're close to about 10% of the IC50 when we look at the Cmax of Lesinurad, which is really nice. That means there's low interaction potential. Now, if you look on this side, O4 and Urate 1, not as relevant actually when you look on this side, because we're talking about the urine side or the ultrafiltrate side. So the Cmax there, we don't know what that is. We don't actually know the Cmax because you'd have to measure after the water's absorbed. So that's a more complicated measurement. So the Cmax is actually referring to the blood Cmax, which is really more relevant for the transporters that are on the blood side. That'd be O1 and O3. And I'd like to thank you for listening to this. If you have any questions or comments, you can email me at adam.vanwert@wilkes.edu. Thank you very much. Have a great day.